I'm going to go ahead and introduce the next speaker, but first I realized that we didn't introduce our maternal child health equity postdoc. So you heard from Kiara, who led the Q&A in the previous session, and then we also have Ehi, who will lead the Q&A in this one, and I'll let Ehi just say hello when we get to that point, and then next time when we have Kiara, she can introduce herself too, because we're so delighted to have them with our team now. So I'm going to go ahead and introduce the next speaker now. I am delighted to have Molly Strothkamp here. She is the Senior Program Manager of Mental Health Services at Southwest Human Development's Birth to Five Center of Excellence. She's also a faculty member at the Harris Infant and Early Childhood Mental Health Training Institute. She earned her MSW from right here at Arizona State University and completed a 2-year Harris Infant Family Clinical Practice Program in 2007. She provides mental health consultation to home visiting programs and trainings on infant mental health to parents, professionals, and community organizations. She's endorsed as an infant mental health specialist and is rostered in the child parent psychotherapy. So Molly, thank you so much for being here.
Thanks so much. I'm happy to be here with you all. I'm going to share my screen. Thank you for the introduction. Let's see. So I'm happy to talk with you today about a topic that I feel really passionately about, and hopefully I imagine that some of you will also feel that, because it's just such an important way to think about humans and how we start early on and how important relationships are in our lives. So first of all, I've got my conflict of interest financial disclosures. I work at Southwest Human Development. I've been there for 24 years and 1 day, because yesterday was my anniversary. So very exciting. Let's see, I am also rostered in child parent psychotherapy, also trained in circle of security parenting. Those are concepts that I will most likely mention. And then I'm a member of the Infant Toddler Mental Health Coalition of Arizona and a former board member for that organization. And no other financial or non-financial disclosures to report. So welcome, everybody. Again, thank you for the introductions. I saw some familiar people and some new people. So again, really, really happy to be with you. I'm a licensed clinical social worker. I specialize in the mental health of very young children and their caregivers. And for 22 of my 24 years at Southwest Human Development, I have been a home visitor and worked in a couple different areas related to child development and to mental health. So what we're going to do today in our time together is talk about what infant mental health means and the importance of relationships. I'm going to talk about trauma and young children, and then we will talk about supporting children and caregivers. I hope that underneath everything that I say, you hear two important messages. The first is hope, that there is always hope. There's nothing that can happen to a child that we cannot help, that we cannot support them through. And I'll just kind of cut to the chase. The first step in treating trauma with young children is safety. We make sure that they're safe. And children find safety in their relationships with their primary caregivers, their go-to people. And so when I say that primary caregivers, go-to people, I'm talking about parents, talking about grandparents, aunties and uncles, other relatives who take primary care of children. I'm talking about foster parents, and I'm talking about childcare providers and teachers, that these are the caregivers in young children's lives, and these are the relationships where children find safety, where children who have experienced trauma can heal and recover from those experiences that they've had. But underneath everything, again, I hope that you hear those two concepts from me. The hope, I don't care what Google says, there really is always hope, and safety, on how important safety is. So this is an evocative topic. people come to hear me speak about trauma and about young children and the mental health of young children. And I think, especially when I'm talking with professionals, they're expecting to be thinking about the children that they work with. And of course that happens, but also people find themselves thinking about their relationships with their own children, which is a totally natural, normal reaction to this information. People also may find themselves thinking about their own childhoods and their parents as well, that this can really be an evocative topic, evocative work. And so I just ask everybody to go easy on yourselves as parents, as professionals, and to go easy on your parents. And that will start off with shared understanding, hopefully, that people do the best they can with what they've got at any given time. Sometimes it's not enough, and we'll talk a little bit about that. But if we can start there, even if I wasn't talking about trauma at all, just talking about babies and relationships with caregivers can bring things up for people. So if you need a break, put me on mute or anything like that, feel free, do whatever you need to do to take care of yourself. And again, I hope that you hear these underlying messages of hope and safety, even when we're talking about some of the more challenging things. So to start off, this is what all kids need. All kids need safety. Safety is our foundation of everything. Children grow, they develop, everything happens for them within the context of their relationships, and hopefully a foundation of safety within those relationships. All children also need consistency and predictability. Consistency and predictability help to support that sense of safety, especially for kids who've experienced trauma. A lot of times trauma comes in, it leaves us, it can come in a very chaotic way, it can leave us feeling helpless, hopeless. When there is consistency and predictability, this can help kids to restore that sense of safety. And the other thing that all children need is an emotionally available caregiver, a caregiver who's able to stay present with them, even when the child is having a hard time. So I'm going to ask everybody to take a minute and just think about an adult that took good care of you when you were a child. Someone that took good care of you when you were a child, a parent, a relative, a next door neighbor, a teacher, just one person. And I'm going to ask you to think about how you felt when you were with that person. If you can't think of somebody, you're not alone. Not everybody gets that in childhood. So if you can't think of somebody specifically, I'd ask you to think about how you would have liked to feel in a relationship where you were taken good care of. And if you're comfortable, I'd love to see some of the feeling words in the chat box. Oh, I don't know that actually everybody can put them in. Okay, so because we're in the webinar style, that's okay. So typically some of the things that we hear are safety and security, that people felt loved, cared for, seen and heard, really, really powerful feelings. I like to write them on a board behind me and just keep them up as a way to think about what we want for children. This is what we want for children. We want them to feel safe and loved and secure and seen and heard and all of these things. And what we know is that when children feel this way with at least one adult caregiving relationship at some point in childhood, that relationship can become what we call a protective factor. And what that means is that if you know what it's like to feel safe in a relationship when you're a little kid, then you know that safety exists. And when you know that safety exists, it helps you not just in childhood, but throughout your life to look for safety in other relationships, in other situations. So from a mental health standpoint, the goal for young children and their mental health is to make sure that they have at least one caregiver, and hopefully every caregiver, but at least one caregiver where they feel safe within that relationship. So on the flip side, for children who don't feel safe, or children who feel the opposite of safe in relationships with their caregivers, now those relationships aren't protective factors. Now those relationships are potentially risk factors. And again, that's because if you don't know what it's like to feel safe, then you don't know that safety exists. And it can make it harder. It doesn't mean that you're ruined forever, but it can make it more challenging to develop the same healthy coping strategies. Because it's harder to seek out something that you haven't experienced. It doesn't mean that it can't happen. It's like adding an extra barrier into, the capacity to find those same healthy coping strategies. So from my perspective, when we think about early childhood mental health, or what we also call infant mental health, this is really the primary, is supporting the relationship between a child and their caregivers and seeking out safety, consistency, predictability, and an emotionally available caregiver. This is from 0 to 3. This is a definition of social emotional development, or infant mental health. So it's the developing capacity of young children, birth through 5, to form close and secure relationships, to experience and regulate or manage and express their emotions, and to explore the environment and learn. It happens for every child within the context of their family, their community, their cultural expectations. It can look a little different across families, communities, and cultures. As long as the caregiving is loving, consistent, and reliable, we have fairly similar outcomes. We get a lot of referrals in community mental health for children who are struggling in how they express their emotions, and children who are struggling in how they explore their environment. And the main reason that that's where most of our referrals come from is because that's what we can see. Those are the behaviors or the symptoms, how children are expressing their emotions, how they're exploring their environment. And if we think about behavior as though it's the tip of the iceberg, it's what we can see above the surface, and we spend so much time focused on the tip of the iceberg, but we miss what's underneath the surface, the rest of the iceberg. Behavior is communication, and behavior communicates an unmet need. And when we think about young children, behavior is typically communicating one of 2 needs. One, an unmet or unachieved developmental capacity. So for instance, sometimes around 18 months to 2 years old, we see, give and take a little bit there, we see an increase in biting in children in that age range. There can be different reasons why kids that age bite. One big reason is that children of that age are understanding a lot of language and expressively do not yet have the vocabulary to share how they're feeling. And so we do sometimes see an increase in biting there. So that behavior communicates to us an unmet or unachieved developmental capacity. So I'm going to push that aside. The other thing that behavior communicates with young children especially is an unmet need, oftentimes for safety. An unmet need for safety. So we spend so much time focused on that tip of the iceberg. Make sure you see the tip of my iceberg here, the tip of the iceberg. And we miss what's underneath. So we can chip away at that iceberg, but if we don't address the unmet need under the surface, we're just going to end up with a different behavior. So some of the more common referrals that we get oftentimes around young children who are aggressive, having challenges in that way. We also see referrals for children who are doing what we call running or bolting. Those are little kids who take off from their caregiver in the grocery store. They don't look back. Children who run out their preschool classroom door, they don't look back. It scares people. It worries them, understandably. And so they'll refer them and say, we've got to stop him from running. And we do, because it's not safe. And at the same time, whenever we have children behaving in unsafe ways, we've got to push ourselves past that tip of the iceberg, past that behavior, to consider what's happening under the surface. What is this behavior communicating? What is the unmet need here? And so I spend a lot of time thinking about what's happened in early relationships that may have impacted this child's ability to use their caregivers in safe ways. And this isn't to blame caregivers at all, but to consider what's happened when we have a child behaving in unsafe ways. Another very common symptom that we see, this one isn't what people would call a big behavior, because it's not a symptom that gets children disrupted from a foster care placement or expelled from school, but it's something that we see a lot, especially with children in out-of-home placement like foster care, and that is children who are overly affectionate with strangers or indiscriminately affectionate with strangers. We see that a lot. And again, it's not a big behavior in terms of things like expulsion, but in terms of safety, it's a big deal. It's really concerning. And again, we've got to ask ourselves, what's happened in this child's life, in their early relationships, in this family's life, in early relationships that may have impacted the child's ability to interact with adults in safe ways. The reason that typically developing children without trauma histories, without multiple caregivers and placements and things like that, the reason they don't climb into the lap of the AC repairman is because it's not safe. And so when we see things like that happening, we really want to ask ourselves, what's happened here in early relationships that may be impacting this child's way of being safe or unsafe in the world? So when we talk about relationships early on, I'm sure everybody's heard the terms attachment and bonding. They get used in really interesting ways. I'm going to be really clear in how we think about them in the field of infant mental health. So attachment is a child's connection to their caregiver, children attached to caregivers. Bonding is the caregiver's connection back to the child, caregivers bond. So children attach, caregivers bond, and then this creates what we call the attachment relationship. The attachment relationship is all about safety and protection. We see it activated when children are under stress. What happens when this child is hurt? What happens when this child is hungry? How do they use or not use their caregiver? And how does the caregiver respond or not respond in this situation? So attachment is the child's connection, and bonding is the caregiver's connection back, and that creates our attachment relationship. Attachment comes from John Bowlby's attachment theory, which is that as human beings, we are biologically designed to be in attachment relationships with our young for the survival of our species, that babies do things to pull us in as caregivers, and that we as caregivers get pulled in. And you can all think about maybe the last baby you saw, baby. So when I say baby, I'm usually talking birth to 5. I do not tell 5-year-olds that I'm thinking of them as babies. They wouldn't like that. But when I say babies, I'm thinking birth to 5. But for this right now, think about like a baby, like a 6-month-old. Maybe the last one you saw, maybe your baby, a friend's baby, a family's baby, family member's baby, a grocery store baby, the last baby that you saw. And think about what it was that made you want to move closer to them, what they did, how they looked, that sweet like baby smell, all of those things that pull us in. This is part of attachment theory, that babies do things to pull us in, and that we as caregivers get pulled in. It's an evolutionary theory for the survival of our species. But things can get in the way. We can have children, babies even, who stop putting out cues, who stop pulling us in. And we can have caregivers who don't get pulled in, or who get pulled in a way where maybe they're responding in a misattuned way, in a different way than what the child is cueing for. Excuse me. So there, of course, can be different reasons for this on both sides. One of the big ones that we see for children who stop putting out cues can be related to histories of neglect, of not getting their needs met. We also see children do what we call miscuing, where I had to double check and make sure my closed captioning got miscuing right. It did. Okay. In miscuing, that would be where a child cues for the opposite of what they need. So maybe a child falls down and gets hurt, and instead of crying or reaching for or calling to their caregiver, they jump up with a big smile on their face and run in a different direction. Or a child who's thirsty and asks for something to drink, and when the caregiver gives them something to drink, the child rejects it, dumps it on the floor, throws it across the room, asks for more to drink. So again, there's different reasons why this can happen. When children have the experience of not having their needs met, sometimes those children may then struggle to express their needs or to cue for what they need. Sometimes children who have not had their needs met in a consistent way or a safe way will do the miscuing when their needs are met, because it's like confusing. So in my experience, when I have a need, that need is not met. But when I'm with you and I tell you that I'm hungry, you feed me, and I'm not really sure what to do with what's happening right now. The miscuing especially can be very challenging for children, obviously, and for their caregivers. It is hard to feel successful as a parent and as a caregiver when your child is expressing a need, you're thinking that you're meeting the need accurately, and they're rejecting it and then queuing again for the same need. This can be really, really hard for caregivers. A lot of my work has been around supporting caregivers and understanding what's happening in these situations and how we can help support children to cue for what they need and get their needs met. So on the flip side, we also have caregivers who maybe aren't responding or aren't responding in safe ways to a child's cues. There can be a lot of different things that can contribute to that. We might have a caregiver with their own unresolved trauma history, with a lot of stress in their life. We have a lot of caregivers who are not getting enough sleep. And that can be extremely stressful. Certainly mental health needs. There's a lot of research on caregivers with depression. Sometimes that can get in the way. But that being said, it's not black and white. There are plenty of people who have challenges related to depression and don't have any difficulties responding to their child's cues. So I think it's important to say that. One of the big things that can get in the way for caregivers that we see a lot, but often gets missed, is what Selma Freiberg, who's like the mother of infant mental health, she called ghosts in the nursery. That our early experiences of being cared for and being parented, that we bring those with us when we become parents and caregivers ourselves. And that when we've had early histories where we didn't have our needs met, or maybe they were met in inconsistent or frightening ways or things like that, that we bring those experiences with us as these ghosts in the nursery. One of Selma's students, Alicia Lieberman, later coined the phrase angels in the nursery too, to remind us that it's not just the negative experiences that we had that we bring with us, but also the positive ones. So even how we started of thinking of someone who took good care of you when you were a child, that's kind of an angels in the nursery moment too. But this is a big one, like I said, that gets missed a lot, people's own histories of being cared for. And again, that being said, there are people who had very abusive or neglectful childhoods who don't have any difficulty responding to their child's cues. And so I want to be really clear on that as well. Another really big one is substance use. What's really hard for infants and young children when their caregivers are using is that caregivers tend to be up and down in their responsiveness. And this can be really difficult for children to organize around. Sometimes when I need you or I express a need, you meet that need. Sometimes you do not. And so this can be really tough for kids too. That being said, nobody wakes up in the morning and says, I'm going to become, an addict today. And part of being trauma informed is shifting our thinking from what's wrong with this person to what's getting in the way for this person or what's happened for this person. If we care about children, we have to care about their caregivers. They are a package deal. Children literally cannot exist without their caregivers. So when we think about counseling in terms of like couples counseling, we think about, the client isn't one partner or the other partner in the couple. The client is the relationship between them. And this is true of infant mental health or early childhood mental health as well. The client isn't the child or the caregiver. The client is the relationship between them. And how are we supporting that relationship between them? So with attachment, it is a process. It is not instantaneous. And it's long-lasting, unique, and specific to specific relationships. So children can literally look like different children in different relationships based on the type of attachment relationship they have with that caregiver. I can give examples. I know some of you have heard me speak before. So that means that you have to laugh if I tell the same joke, and I'm probably going to tell, the same jokes occasionally. But I will tell this story, and I do tell it a lot, but it's such a good example of this. Many years ago, actually, literally decades ago, I got called out to see a little one. I think he was about 2.5. I'm pretty sure I was called out initially for aggressive behaviors. A lot of times that's when children are referred for services. So I went out, I rang the doorbell. The 2.5-year-old opened the door, which I'm not a fan of 2.5-year-olds opening the door to strangers, but I feel like I have to disclose that because that's literally what happened. Anyways, in this case, it didn't matter because he looked up at me, he spit in my face, he kicked me in the leg, and then he ran back into the house. So I went home. No, I'm just kidding. Occupational hazard. So went in the house. He was home with his mom. And they were seriously struggling. He was all over the place. He wasn't using any language at 2.5. We didn't see any typical play skills. And he was aggressive towards mom, towards the dog, towards me. And I know at the beginning I mentioned children who are overly affectionate with strangers, how that's a concern. Children who are aggressive towards strangers, that's a huge red flag. I am a lot bigger than a 2-year-old. He's never seen me before. He has no idea how I'm going to respond. It's a very unusual way to be with strangers in the world. So I encourage you, if you're working with, you come across a child who's struggling in that area with aggression towards strangers, that would be a situation where I would want to up the supports and services for the child and family. That's a pretty big concern. Anyways, so it takes me about 6 weeks to do a full assessment, which is hard. Usually by the time I'm involved, families are pretty desperate for help. And so it's hard for them, of course, they want me on that first day to tell them exactly what to do. And that's not really how this works. And it takes about 6 weeks because it's important for me to have a sense of what's happening. I don't want to treat the wrong thing. So I left, I came back. Each time I came back, pretty much same presentation. They were both really struggling. I think it was maybe the fifth visit I came out, I rang the doorbell, 2-year-old opened the door. We hadn't even touched that issue yet. But he looked up at me and he said, "Molly, come in. I want to show you my trains." And this literally was like more than 20 years ago, but I remember I looked at my watch and took a step back and looked at the house. I was so confused. I literally thought I was at the wrong house. But nope, it was the same child. Followed him in and he was home with his dad. And he felt safety and security in relationship with his father, and he could organize around his father. He could access language. He was not aggressive. We played trains for about 45 minutes. Typical play skills, literally looked like a different child. And this is how specific attachment relationships can be. Children can literally look like different children with different caregivers. This is why for professionals, it's especially important for young children that we assess them across all their caregiving relationships. Parents, any relatives who are providing primary care, foster parents, childcare providers, and teachers. So he felt safe with his father, and he could organize more clearly in a way around his father where he looked like more typical with his development and symptoms and all of that. He didn't feel safe with his mother, and that's not to blame her. Once again, had to do with her own ghost in the nursery, her early experiences, kind of coming back up for her in her parenting role. And I think about him a lot because in that situation in the family, because I think about how easily he could have been diagnosed with something like ADHD and put on medication. And I'm not anti-ADHD diagnosis or medication or anything like that. I've seen children respond really well, but we've got to make sure that we're treating the right thing. And what he had was a relationship disturbance with his mother. And there's a whole lot that we can do in therapy to help and support them through that. But I think what's really important for us to keep in mind is that children can look so different and different relationships. In the world of children in foster care, this is really hard for people to understand, really hard for professionals to hold on to. Oh, and I also want to say there can be different reasons for why a child might look different with one caregiver versus the other. So in that situation, it had to do with his relationship with his mother. But in some situations, children hold it all in until they're with the caregiver that they feel safest. And that's where they let it out. So it's a compliment. I know it doesn't feel like a compliment, but there it is. So there can be vastly different reasons for why children may present in different ways with different caregivers, which again, just adds to the complexity of the field of early childhood mental health. And so we see a lot of people struggle with this for children in foster care, out of home placement. A lot of people struggle with scenarios where maybe a child is doing visitation with a biological parent, and the biological parent is saying, "Hey, everything went great on the visit." And then the child is returned home to the grandparents' house or to the foster home. And they say, he's been completely out of control since the minute he walked through the door, hit his sister, destroyed his room, didn't sleep for 3 days. And by the time he started to seem like himself again, he was going back for another visit and it all started over again. And I see really well-meaning professionals take sides on this. They say, well, of course the biological parent said he looked great there because she's a Disneyland parent and she lets him eat hot Cheetos and play on her phone for 3 hours. Or they'll say, of course the placement said that he looked terrible afterwards because they're trying to sabotage the case because they want to adopt. People take these really, really strong stances. And in reality, there can be so many different reasons why a child might look different. And both caregivers could be totally correct that he looked fine on the visit and does not look good afterwards. And again, a lot of different reasons for that. Sometimes what's happening is the way we're transporting children to the visits, that's actually re-traumatizing for children, sticking them in cars with strangers to go, a couple hours across town or across the state to visit maybe a caregiver that they are desperately grieving and missing, maybe to visit a caregiver that they don't know very well. They're just trying to get a relationship going. And in some cases, children are being transported by strangers across town to see somebody, the person that they're the most afraid of in the world. And all of those things can contribute to why a child might present or look very different in different settings. So again, I think one of the big things that we can take away from this is, one, making sure that we're assessing children across all of their relationships, young children. And two, just slowing things down, not jumping to conclusions, but to consider the different possibilities of what could be contributing to why a child might be struggling in their different relationships. So I could say a whole lot more about that, but we have a short amount of time and I want to make sure I leave time for questions. And I wanted to talk about trauma as well. So anytime I talk about trauma, I always start by talking about attachment and safety and relationships for a couple of reasons. One, it's really important to me that we all have a shared understanding of how important early childhood relationships are for children. That is such a foundation for them. So having that shared understanding. Also, sometimes children experience trauma within those relationships, and it's important for us to know that. But for me, even more important, like the most important thing, is that children heal from trauma within those relationships, their caregiving relationships. This is why in best practice for mental health for children under 5, you would never see me meeting one-on-one with a child. The caregiver would always be there because it's not about my relationship with the child. It's about supporting the relationship between the child and their caregiver. You might see me meeting one-on-one with just the caregiver. That does happen quite a bit, but one-on-one with the child, unless the child absolutely has no caregiver. But even in that scenario, maybe they're in a group home, and we do see children under 5 in group homes. Even in that scenario, there are adults there that we can support that are providing primary care for children. Also, when we think about trauma and young children, it's important to think about how trauma and attachment kind of collide in a way. I don't know if collide's the right word. I might, like in 2 hours, think of a better word, but we'll go with that for right now. One is that children, when traumatic events happen for children, they can lose the sense of their caregiver as someone who can keep them safe. Even when it's absolutely not the caregiver's fault. You can have a parent driving down the road, following the speed limit. They have their seatbelt on. The child is buckled safely in the car seat. They're following every rule, doing everything right, and someone else can hit them. And when that happens, children, the world can look different. Children can see the world in a different way. They can lose a sense of their adult caregiver as someone who can keep them safe. And at the same time, parents can lose the sense of themselves as able to protect their child. That's why in the kind of therapy that I do, child parent psychotherapy, we focus a lot on what we call restoring the protective shield, supporting caregivers to feel that they can protect their child again. And I could give examples from current events, unfortunately, from community violence, school shootings, natural disasters, things like that, and the experiences where children now can see the world in a different way, and parents may see themselves as less protective. Or for instance, children, not from a political place, but from a mental health place, children being separated from caregivers at the border, something like that. I've seen some talk, some writing about how the kinds of supports children may need after an event like that. And I don't ever see anything about the kind of support parents would need after an event like that. If we want children to be okay, we have to make sure that their parents are okay, that their caregivers are okay. There's a saying, I say this a lot because there's many sayings, but one saying in my field is that if you want to know how a young child is doing following trauma, look to their caregiver. And that's because, again, if we want kids to be okay, we have to make sure that their caregivers are okay too. And thinking about how do we restore this protective shield, help caregivers to feel that they can keep their child safe again when there have been experiences where they were not able to do that. So there's a lot of definitions of trauma. I like this one from the diagnostic classifications 0 to 3, the revised edition, because it leaves things very broad. Trauma can be something that a child directly experiences or witnesses. It can be an event that involves actual or threatened death or serious injury to the child or to others, or it can be a threat to their psychological or physical integrity for the child or for others. Really, really broad, because I think one of the really important things to keep in mind about trauma is that trauma is in the perception of the person experiencing it. What's traumatic for me might not be traumatic for you. What's traumatic for one 10-year-old might not be traumatic for another 10-year-old. And what's traumatic for a 4-year-old might not be traumatic for a 1-year-old. So keeping this in mind, sometimes trauma in young children gets missed because we don't realize how they experience the event. This is from the National Child Traumatic Stress Network, which is one of my favorite resources online for parents, for professionals, teachers. And they're very helpful in doing one thing that we can all do to be more trauma informed, which is to expand our emotional literacy, our emotional vocabulary, to be able to talk and stay present when people talk about hard things, which can be really, really hard. I mean, if we were in person and I asked how you are, there's a good chance, a really good chance that you would tell me that you were fine, no matter how you are. And it's kind of how we are in the world a lot of the time. This is hard for kids. If you're a child and you've experienced a traumatic event and no one talks about it, you're not like, oh, I guess that was no big deal. What happened to me? A lot of times we re-traumatize children because their experience is more likely to be, what happened to me was so horrible, we're not even allowed to talk about it. And we make trauma unspeakable. So again, part of our trauma treatment for young children through child-parent psychotherapy is to support caregivers to be able to speak the unspeakable. To let children know that there is nothing that can happen to you that is too big for me to hear, which sounds, like, okay, yeah, that makes sense. But for a lot of caregivers, they need support to be able to do that. A lot of times we have children and caregivers who have been traumatized together and can actually be triggers for each other related to the trauma. So I really appreciate the National Child Traumatic Stress Network because they're so responsive when traumatic events happen. They put out information pretty quickly about how to talk to kids of all ages, about how children of different ages might experience things or interpret things. So I think that it really is a great resource. From the National Child Traumatic Stress Network, when we're talking about a traumatic experience, we're not just talking about something stressful. We're talking about something that can result in overwhelming terror, horror, and helplessness. Children aren't really designed to experience overwhelming terror, horror, and helplessness. I myself don't want to experience overwhelming terror, horror, and helplessness. But children are designed to turn to caregivers under stress. Remember, back to attachment, to turn to caregivers under stress. So our biggest risk factors here are when a child experiences overwhelming terror, horror, and helplessness, and they turn to their go-to person, and that person is the source of the terror. What do? Our next big one is when a child experiences overwhelming terror, horror, and helplessness, and they turn to their go-to person, and their go-to person is terrified themselves. And again, this isn't to blame parents for being terrified, but to recognize the different experience for a child when their caregiver is terrified. And it could be that the caregiver is also experiencing trauma, and that's where the terror comes from. Sometimes also we see caregivers who are frightened of their child. And so this puts us in that kind of same category of not being available in a safe way for children under times of overwhelming terror, horror, and helplessness. So another situation that can be quite challenging. And then our third really big one is when a child experiences overwhelming terror, horror, and helplessness, and they turn to their go-to person and nobody is there. And that can be that they've been left home alone. And I've worked with many children over the years, young children who were left home alone for extended periods of time. That is terrifying for them. But it can also be when we have a caregiver who is physically there, but not actually present, whether they're using, whether there's, some mental health things going on, whatever else may be happening for them. Those are really our big risk factors for children when they've experienced trauma. So I'm not going to go through all of these, but these are some potentially traumatic experiences for children. There are 2 asterisks next to witnessing domestic violence, and that's because post-traumatic stress disorder, PTSD, I can diagnose in children as young as 12 months old. I can go down to 10 months old if I have enough evidence. And our biggest risk factor for a very young child developing post-traumatic stress disorder is not actually being hurt themselves. It's witnessing violence or a threat against their caregiver. That's our biggest risk factor for PTSD in very young children. And that's because if I'm a little kid and someone's hurting me, at least I know I have my go-to person and they can help me. But if I'm a little kid and someone's hurting my go-to person, we're both in big trouble. So it's important for me to highlight this. I do a lot of consultation to different agencies and professional teams working with young children and families. And I find that, people shorten this down to DV or IPV and kind of just throw it in there as part of the demographics of what may be happening for a family. And I just like us to really slow down and consider what that may mean within that family and within that child's relationship with their caregivers. So again, trauma is in the perception of the person experiencing it. Some of these things may be traumatic for some children, some of them may not be. I can talk for a long time, so it's really hard for me to not stop and go through a couple of these. Okay, so I just want to say, I couldn't stop myself. I just want to say something like medical trauma, I think is a really good example. I work with a lot of children who have experienced physical abuse, neglect, or sexual abuse to the point that they require hospitalization, medical treatment afterwards. And I found that people have space for the traumatic experience of the actual abuse or neglect. And a lot of people miss the other points of potential trauma along the path of this. So keeping in mind that trauma, it can be one event, but it can also be multiple events or one event extended. So in a situation where we have a child who experiences abuse that then requires hospitalization, we might have a trauma point related to the abuse. We might have a trauma point related to whatever happened with the 911 call, if the police broke down the front door, if anyone was taken out on a stretcher, if the child rode an ambulance to the hospital. Also in some experiences like that, while the police are trying to determine who is responsible for the abuse, we might have a child experiencing painful medical procedures in the hospital all alone, that maybe nobody is allowed from the child's life to visit them while the police are sorting out what's happening, understandably. And at the same time, that may be another potential trauma for this child. So in terms of trauma treatment, the more information I can have about potential points of trauma, the more we can do to help children process what's happened to them, to help caregivers support children in processing what's happening to them. Trauma derails the developmental trajectory. Trauma in young kids can look like other issues. Trauma can look like anything. Trauma can look like ADHD. Trauma can look like medical issues, relationship disturbance, depression, anxiety. So I'll give you just a couple of rules of thumb when we think about diagnosing very young children, because I think that it can be helpful in how we organize around what may be happening. Trauma trumps everything with 2 exceptions when I'm diagnosing. So the first exception is medical. Medical trumps everything. Medical first. We have to rule out medical, and this is an ongoing thing. This is important to keep on the radar as a possibility. I can't tell you how many children that have been referred to me for trauma, and it turns out the child has undiagnosed type 1 diabetes. The symptoms can look the same, or where the child has a seizure disorder or undiagnosed cerebral palsy or any number of things. So we want to keep medical in the forefront. The other thing that can be especially complicated with young children and trauma is autism spectrum disorders. So I'll move that to the side for a second. I cannot diagnose anxiety, depression, anything else unless I can rule out trauma, because trauma can look like anything. The exception is autism. And autism and trauma in young children, very complicated. And there is still hope. We can still absolutely help support them. But it can be a little tricky sorting out what we're looking at or what's happening, because children with autism can look like they have trauma. Children with trauma can look like they have autism, and children with autism can experience trauma. So all of these things are possible. The good news is that our treatment for trauma in young children is to make sure they're safe. And you're not going to hurt a child with autism by making sure they're safe within their relationships. You're not going to hurt a child with anxiety or depression by making sure they're safe within their relationships. So that gives me a little bit of comfort, because it is very challenging. The younger kids are, the harder it is to differentiate what we're looking at. So a lot of times we work to keep things fairly broad and focus on that safety with caregivers early on. Just for the sake of time, I'm not going to spend a lot of time on this. I'm not putting up a list of symptoms. You can Google that and find all kinds of stuff. I don't think that's really helpful. Trauma can look like anything in a child. You can take a sibling group of 3 who experienced the same event, and all 3 of them can have very different presentations afterwards. So I'd really encourage people, instead of looking to a list of trauma symptoms, to just look to the child in front of you. What are they struggling with? Is there anything impacting their sleeping, their eating, their daily routines, their emotional regulation, anything getting in the way with their relationships, with school, with things like that? There are our trauma symptoms. So looking to the child first, instead of looking to a list of symptoms, because every child will present in different ways. It is important to keep an eye out for kids who have both the external symptoms, the overt big symptoms that we see, but also the kids who pull in. The ones who are quiet, maybe really easy, have more of internal subtle symptoms, they're much more likely to get missed for supports and services. So we've got to kind of keep our radars open for them. Our best predictor of how children will do following a traumatic event is their caregiver's ability to cope with the trauma. Their caregiver's ability to cope with the trauma. Again, how are we supporting caregivers to restore their protective shield, to help them feel that they, to help support their efficacy as parents, and to feel that they can keep their child safe? All right. So here for the last section, and then we'll have time for any questions that you all have. What do kids need? Again, they need safety, consistency, predictability. Consistency and predictability support safety. Routine support safety. And an emotionally available caregiver also supports safety. We can help by helping people push past that tip of the iceberg to tune into children's emotional states and what they need, rather than putting all of our focus on behaviors and trying to stop behaviors or change behaviors. If we stop or change behavior without addressing the unmet need, we still have an unmet need. We're just going to end up with a different behavior. But if we can meet the unmet need, that will change the behavior. So helping parents, caregivers, teachers, grandparents to focus on what's happening under the surface, and to help other professionals with that as well, too, to shift all of the focus from behavior to what the behavior is communicating to us. What is the unmet need? We can help children by encouraging supports in their family to natural supports. As I said before, caring about children means caring about their caregivers. And what we know is that when parents feel more supported, it helps them to be more emotionally available to their children. And it can help children to organize or attach in ways that can help them to have access to that protective factor from the relationship. So when you're working with children and families and you're talking to a parent about them, going back to school, or maybe their cousin moving to town, or they made a new friend, or any of those things, all of those conversations are in support of the child. Because when parents feel more connected, it frees them up to be more emotionally available to their children. So looking for natural support systems. I do have, I've had a lot of opportunities to work with families for extended periods of time, which I really appreciate, but I am temporary. And so it's not about me being their only source of support. It's about really helping to connect children and families to people that will be there, to supports that will be there, whatever that is for the family. For some families, you know, it might be faith-based or religion-based. For other families, it might be connected to like the local soccer club or different parenting groups or things like that. So really tuning into the supports that parents, that individual parents and families feel, what's important to them, that doing those things helps support children. So some of our resources, we have the Birth to 5 helpline at Southwest Human Development. And this is caregivers can call, parents can call, professionals can call. You can call about a 6-year-old, they're not going to hang up on you. And they know about resources across our state for young children and families, and they're very, very supportive. So it's a warm line available for them. Also, I teach twice a month a free class for the community, for parents, foster parents, professionals, anyone interested in learning more about trauma and young children. And it's kind of based in, well, it's definitely based on what we talked about today, but a bit more in depth. And so that's available as well. But I think one of our really big resources is this Birth to 5 helpline, because they know all of the other resources too, which can be very, very helpful and supportive. All right, so I just wanted to take a minute to talk about what it means to be an infant mental health specialist, because a lot of people think, well, this must mean that that you're a therapist or have all this training, or that you have to be like a licensed clinical social worker or something like that. Sure, I mean, that person can be an infant mental health specialist, but really an infant mental health specialist is anybody who operates from this way of relationship-based thinking, who focuses on the importance of the relationship between children and their caregivers and supporting that relationship to support the child's health and development, and to support the caregiver's health and development and wellness in support of the child too. So that's what it means. You don't have to be a mental health clinician to be an infant mental health specialist. This is from Jeree Paul, another student of Selma Freiberg. And our quote here is that each interaction is an opportunity for you to make children and families feel heard, appreciated, and understood. When parents and caregivers feel this way, this can help support them in providing this to their children as well. So I like this quote. And 1 second here. Please hold on to the importance of safety and children finding safety in their relationships with their primary caregivers, and hope that we can help children even when horrible things have happened to them, that we can help families, that we can help caregivers, and to not give up hope, to hold on to that hope. And the other thing too, whatever your role, if you're here as a parent, a student, a professional, I imagine most, if not all people here are helping professionals in some way. In order to help other people, we really have to take care of ourselves too. And so to keep ourselves on that list as well, also helps us to keep hope and safety present when we're taking care of ourselves. And that is like infant mental health, early childhood, the importance of relationships on super speed. Are there questions? Can I help? Thanks for all the little emojis. They're like floating across my screen. And I'll put that trauma class in here too, Liz, if that's okay, the link for that.
Yes, thank you. People, I see people were asking for that, so we'll be sure to share that.
Thank you.
Hi, everyone. Thank you so much, Molly, for your presentation. My name is Ahiramen Azugbene. Just like Katie said earlier, I'm one of the maternal and childhood equity and postdoctoral fellows with the MCH charity team. And I will be doing this, conducting this question and answer session. Very great presentation there. I think the first question for you is how someone is asking, April is asking, how can we get more information about those trauma classes?
Yes, absolutely. I did put, thank you for the question. I did put the link to more information and the sign up for that into the chat box. I'll also provide you with my email address in the chat box. I'm happy to help if the class is sold out, which does happen. It's on Zoom, so we can find room.
Okay, thank you so much. I think the second question comes from Maria Lujan Tumasini. If I said the name right. She says, thank you for bringing the focus of the conversation to the fact that we cannot help children isolated from their caregivers. I really appreciate your presentation, Molly. So it's more of a comment. Thank you so much, Maria. And then the third question for you is, can you explain more about trauma and autism?
Yes, yes. In the next 4 minutes, I'm going to totally demystify that whole thing. No, I'm sorry. That was a terrible joke because it's really complicated, but I appreciate the question. It's really complicated, especially with very, very young children. So symptoms of trauma and characteristics of autism can look similar. And that can be tough to sort out. A lot of people, a lot of professionals understandably see the world through their lens, through what they know, what they're trained in. And so maybe you have a child who has whatever characteristics or symptoms they're showing, and maybe a professional whose focus has been a lot more on autism spectrum disorders, and that may be what they see. Whereas maybe you have a mental health clinician whose focus is on trauma, and that's what they see. That's one of the reasons that it's really, really helpful and important that we have professionals who know about very young children, who know about autism, who know about trauma. And a lot of times this, the best way to do this is to have multidisciplinary teams, that nobody's going it alone, but that we have people with different lenses thinking about a child and family together, so that we're not missing one thing because our lens is so focused on something else. I wish I could give you more. Feel free to come to my trauma class. I did go a little bit more into depth there as well.
Thank you so much, Molly. I think the next question is, what effects have you seen of phones mimicking depression? Saw an article on this recently, the face of a parent distracted on her phone being similar to those of this depression. Any advice to give?
Oh, that's really interesting. I haven't read that article, but it immediately reminded me, or made me think of the still face research that has been done and repeated. And I think that can be really interesting to look into. I can't speak specifically to the article that you're talking about, but I think that there's a lot that we could think about in terms of children's cues and caregivers' responsiveness and things that might get in the way, whether that's phones or other things happening for them. And then we can also think about the different reasons why caregivers might be on their phones, and what need that might be meeting as well. Like really, before we try to change behavior, whether it's for children or adults, we want to really think about what is the function? What is the function of this? What is the need, the unmet need that this behavior for children and adults may be meeting, so that we can have a better understanding of what's happening.
Thank you so much, Molly. And the next question is from Jeanette Mallory. And she's even asking the question I was going to ask myself. She says, thank you for your presentation. What cultural considerations are given when working with families? So what cultural considerations are given when working with families?
It's such a great question. And it's such an important part of the work, because we really do, hopefully, slow down to understand and have conversations with families about what's important to them, about their culture, meanings they find, things like that. Really a focus on, I would say, cultural curiosity in this work. because it does have such influence, an important part for children and families. So it's really helpful when we have clinicians and infant mental health specialists who have that cultural curiosity so that we can learn about each family within their family and their community and their culture.
Corey, do you want me to move on, or did you want to add to what she's saying? Hi, Corey. Did you want me to move on? Did you want to add to what she's saying? You want to answer this question live?
We're just marking off the questions in the
I'm just
queue.
marking them off. as we
okay,
answer
okay.
them. Sorry, my bad.
Sorry.
Okay, so the next question is, the next person's comments, the next comment is from Teresa Vargas, and she's saying, Molly, your presentation is excellent. The next comment is from Alicia Jacobo Kenny, and she's saying, fantastic presentation, well delivered. And Maria also makes a comment, and she's saying, infant and toddler mental health is the foundation of how my understanding of everyone I treat in my practice. Wonderful job encapsulating this theory so effectively.
Oh, thank you. I really appreciate that. I appreciate that feedback and of course the compliments. And I feel the same way, that this is really my theoretical orientation and what I'm grounded in. And I can talk for hours about this. So I'm glad that the message got across in the time we had together this morning. Thank you so much for everybody. Thank you to ASU and everybody involved for having me here.
Thank you so much.